Hello, everyone. It's a great pleasure to be with you for NCVH Digital Education Series. I hope you're all doing well during the pandemic. I want to specifically thank Dr. Walker and NCVH for hosting this event. And today, what I'm going to be speaking on is a guide wire that sizes vessels, something that I've been particularly excited about and waiting for it to come to fruition and see it in our labs and utilized. So here are my disclosures. As Dr. Walker's fellow several years ago, one of the first lessons that he taught me was about sizing. He said, Pradeep, not too large and not too small, just the right size. He told me this when I asked him what size balloon should I grab. And you know, the concept is fairly straightforward. He calls it the Goldilocks of sizing. If we go too big, we're going to risk perforations or restenosis, or potentially dissections. And if we go too small, we're not going to treat or risk restenosis, or if we undersize our stents, it could be a catastrophic problem with stent thrombosis. And what we can see is that sizing is very important. In animal models, oversizing can lead to significant neointimal hyperplasia. If you simply oversize by even a mild amount, 1.3 to 1.6 to 1 compared to the vessel size, you can get significant neointimal hyperplasia, and highly oversizing yields tremendous hyperplasia. So this is an important concept that was also identified in our stent trials in the Supera stent. When we want to deploy a Supera optimally, we all know who deploy them that prepping the vessel is key. So you need to know what size your vessel is. You need to make sure that you adequately dilate the vessel, because if you do not, what will end up happening is you can either elongate or compress the stent, but patency can be significantly affected if it's not deployed to a nominal length. But when it is deployed nominally, because you know your size of the vessel, there is definite improvement in patency with those stents. And the Gore Viabond similarly showed the importance of sizing. If you oversize the stent by more than 20% of the vessel size, what you end up seeing is a significant reduction in patency. So if you oversize, what happens is there's typically these edge stenoses that can occur that then need to be addressed relatively early to avoid thrombosis of the vessel. But if you size it well, these stents have great patency. Drug-coated balloons, similarly, we know that this is imperative that you size it 1-to-1, because if you do not size it 1-to-1, you're going to either undersize it and have downstream particulate washout. You're not treating the vessel. And if you oversize it, you're going to end up with it could end up with a large dissection that may require adjunctive stenting if necessary, if the dissection is very severe. So what do we use for sizing? Well, I mean, I think still, the vast majority of operators out there are using angiography because it's simple. You look at it and decide what the size is and grab a balloon off the shelf. But the problem is that this is really an abstract art. It depends on the obliquity with which you view your vessel. So we have other alternatives for sizing, and we all love, and I specifically like to use intravascular ultrasound rather commonly in a lot of my procedures to help size. There's also OCT that you can utilize, and you can go off of your scans such as CT and MRI and duplex ultrasound for sizing prior to your procedures if need be. But angiography alone does fail. So in a study by Lita looking at IBIS, we see that when IBIS is utilized, patency is improved as compared to just using angiography alone. IBIS, though, has pros and cons. Several pros, for sure, is that you can size your vessels and assess what kind of plaque you have. You have fibrotic plaque, calcific plaque, soft plaque, hard plaque. It's very helpful in identifying that. It can also tell you if your therapy has been completed, if you have good luminal gain post-procedure, or it can help you identify any areas of dissection if you want to treat focal areas of disease. But the cons are it definitely increases your procedural time. Costs are there. It's an added cost, and reimbursement can be variable depending if you're an outpatient lab or in a hospital. And the image quality can be very variable depending upon user interpretation and image gains. So here's a case that I did about a year ago, where I had the IBIS catheter in the vessel, and it looked like a super tight stenosis when you first look at it. But then if you just rotate the camera, the IBIS catheter 180 degrees, what you see is a lumen opening up, and there's just artifact around the catheter itself creating that. So IBIS, you have to be careful when you utilize IBIS to make sure that you're actually seeing what the IBIS is showing you. So this brings us to other types of sizing technology, and this is the Lumen Recon wire, which is a novel wire-based technology that allows for accurate vessel sizing and therapy delivery all in one device. The Lumen Recon shows significant accuracy. This has been validated in studies which I'll be showing you. It's very easy to use and intuitive. It's time and cost efficient. It's a wire. You simply place it, and I'm going to show you how to use it in a few moments. And you can actually deliver therapy over it and treat a vessel all with one device. And ultimate goal would be improving patient outcomes by sizing the vessel right from the onset. So it's really as simple as 1, 2, 3. You have the package of the device, which is a wire. You have a console attached to the back end of the wire. And all you have to do is inject saline in order to get a vessel size. And this is done by the theory of operation and the electrical principle, the physical principle and law of ohms, which we've all learned in grade school or college, or may have forgotten, but it's a simple law where we can solve for knowns and unknowns, and by creating a small and safe electrical current through the wire and injecting a fluid of known conductivity, in this case saline, we can calculate the diameter of the vessel as well as the cross-sectional area, all to within a hundredths of a millimeter. So this is a video of the wire being utilized. So you can see here, you can shape the wire. It's just like a woolly wire as far as its characteristics. It's easily passable through lesions. You can pass it to an area, and you see 4 thermistors which measure electrical conduction. And the middle 2 is where the actual measurement is obtained. And by measuring the conductance during infusion of the saline, you're able to get your diameter and as well as your cross-sectional area instantaneously. And so, as I mentioned, there's 4 electrodes. Then the size are measured between the middle 2. Each electrode is measured, it is exactly 5 millimeters apart. And then you have a console which gives you your size. Now, the preclinical validation was done ex vivo in plastic well models in conditions of no blood flow. And then they did it in microscopically determined diameters and porcine vessels in conditions of no blood flow. And then finally, it was done in swine vessels where there was arterial flow, and it was done inside plastic arterial sheaths of known French size. And so what was seen is that the LR wire had high accuracy in repeated measures within the phantom models and the porcine femoral vessels, as well as high correlation with intravascular ultrasound and duplex ultrasound. And we were able to perform the clinical validation and perform the first study in 24 patients utilizing the Lumen Recon wire in patients with femoropopliteal arterial disease. And what we saw is that the measurements of the LR, each measurement to the other, was highly reproducible, and it was very accurate to the vessel size as compared to what we would see in IBIS quantitative angiography. It was worse with duplex ultrasound, given the variability in measurements with ultrasound and as well as angiography, but it correlated strongly to quantitative angiography, in which we had dedicated sizes noted on the LR catheter thermistors that are 5 millimeters apart, and that's why quantitative angiography showed a close association to the actual vessel size. But it was very accurate and highly reproducible, and this is where I see the future of the device. So if you look at a vessel, let's just say an SFA occlusion, we can cross our occlusion any way we deem fit. This is not a crossing wire. However, once you cross it, all you need to do is pass the catheter beyond the occlusion, and through your crossing catheter, you can infuse saline and measure what the distal reference vessel diameter is. And once you have that, you can perform the atherectomy of your choice. You can use the right size of balloon from the outset, and then you can get the optimal result that you desire for these patients, all with one catheter, one wire, without requiring any other devices. So the future of sizing technology does look promising. You can use it for other vascular beds. It's not solely required to be used in arterial systems. It can be used for sizing the aortic annulus in valvuloplasty. It could be used for sizing venous iliac veins for venous stenting. In coronary arteries, there's been already published data in utilizing another form of the device, which is a sizing balloon for measuring size of coronary arteries. And then there's a whole host of other vascular beds where we can measure vascular sizes. And there's going to be smaller wire-based platforms that are being developed with the hope that we can actually utilize more devices over one wire. And as I mentioned, there's conductance balloons that are also in use, are being developed for the same purposes of sizing. And so to summarize, I'll say that Lumen Recon is a novel 0.35-inch guide wire-based system that accurately and reliably sizes peripheral vessels, utilizing the physical principle of Ohm's law. And this wire-based technology allows for treatment of vessels without the need for any wire exchange. We can get accurate sizing and treatment on one platform, and this hopefully can reduce procedural times, and the ultimate goal is to improve patient outcomes. With that, I thank you.